everybody. My name is Hannah Dins. Thank you so much for joining us today. I'm an assistant director of admissions here at Columbia Business School. I know we have folks joining us from all different time zones, so good morning, good afternoon, and good evening, wherever you might be around the world today. You are so fortunate today to be hearing from Professor Carri Chan. Professor Chan is the faculty director of the Healthcare and Pharmaceutical Management Program and a professor of business in the Decision, Risk, and Operations Division here at Columbia Business School. Professor Chan teaches the core MBA class, Operations Management. Her primary research interests are in data-driven modeling of complex stochastic systems, dynamic optimization, and queuing with applications in healthcare operations management. Her current focus is on combining empirical approaches with mathematical modeling to develop evidence-based approaches to improving patient flow through hospitals, and particularly intensive care units. During today's presentation, please feel free to put your questions into that Q&A box. We will have time for questions at the end. And with that, I'm going to turn it over to Professor Chan.
Thank you, Hannah, and thank you all of you for joining in today. What I wanted to do was spend a little bit of time talking to you about some of the things that I had been doing over the last 16 months. And so as Hannah mentioned, my research is in the healthcare space. And I was actually on sabbatical in the 2019 to 2020 academic year at New York Presbyterian, which is one of the larger hospital systems here in New York City. And I was sitting in a group that was between the analytics and quality branch at New York Presbyterian when the pandemic hit. And so we transitioned a lot of our efforts, or I guess all of our efforts really, to trying to use analytics to address the pandemic. So I wanted to share a little bit about what we had been doing, and so you can get a flavor of some of the work that's been going on at CBS. As Hannah mentioned, feel free to write questions in the Q&A box, and I am happy to answer them as we go through. So to provide you with just a little bit of context of what was going on, in 2019, I was on sabbatical, as I mentioned. That's when it started at New York Presbyterian up until 2020, the fall of 2020. And, you know, as part of my sabbatical, my objective was to further my research agenda, finding ways to collaborate with some of the top providers in our country on ways to improve healthcare delivery. And so that's what I focused the first half of my sabbatical on. And then in November, the first COVID case was identified in China. And then, you know, not that long after, in New York, we had the first COVID case and at New York Presbyterian. And so I remember there was an all system-wide call after that first patient was admitted. And in retrospect, you know, there's a lot we really had no idea about at the time. But I will be really honest, at that time, there was I guess, an optimism that things were going to be okay, that, you know, we expected, being an international hub, that there would be patients with COVID in New York City, but that this was not going to turn into a worldwide pandemic. But we know now that things quickly spiraled out of control, that I think we underestimated the transmittability of this disease. And so quickly, I transitioned my approach to using data analytics to try to help come up with different ways to combat and address the current pandemic. So, you know, some of the work was looking at how to think about the personal protective equipment shortages that were being projected, how to utilize things like hotels for quarantine, where maybe people aren't able to quarantine within their own household. Thinking about ways to do testing better. How do we understand allocation of ventilators when many patients suffer from respiratory failure? And then can we think about what a second wave might look at? And I'm still doing work that's related to COVID-19. I'm working with the Montefiore Medical Center, which is up in the Bronx, on how to do ventilator triage, and we have a manuscript that we're about to submit. I am working with the Columbia University Medical Center with their digital health executive committee to think about how to position their telemedicine strategy going forward, recognizing that telemedicine exploded in the past year. And the hope is that now that patients have experienced it and physicians have experienced it, there's going to be a larger embrace of that visit modality. And so what's the right mix between in-person and televisits? I'm also working with a hospital in New Jersey on how to think about surge planning in the emergency department. So if they notice real time that there are more patients coming in than they have staff available, how do they make decisions on how much staff to call in for surge? So given the time that we have together today, I'm not going to be able to talk about all of these, although I'm happy to talk offline about ones that I am not able to cover with those of you who may be interested. But I wanted to touch on a couple of these projects so you get a sense of the flavor of the work. So I guess the premise of using analytics has been something that has been of growing interest in the healthcare space. I will be very upfront, and for those of you who perhaps work in the healthcare space are hopefully nodding along, I would say the healthcare sector has lagged behind other sectors in terms of the use of analytics. I think that this is for a number of reasons. I would say first and foremost is that the databases that exist, the electronic systems that exist, there was a lack of interoperability, meaning they did not communicate with each other. So you have a different system for every unit within the hospital. You have a different system for staffing, for patients, and for finances, and they couldn't communicate. And so creating comprehensive data sets, that is the foundation of analytic work, just really wasn't possible. The other is, I think that rightfully so, the risks associated with not getting it right, for doing something incorrect in healthcare can be much larger in the sense that this is impact on life and death, or even just the morbidity of patients. So when we think about that landscape, COVID introduced even more challenges. So in that February-March time period, there was very little known about the disease, how it was transmitted, how likely it was to be transmitted, what would happen to people when they are infected. And we know now still that a lot is being learned, right? We don't have a full grasp on it, as we do with other diseases and other pandemics that may have had. The other challenge was that New York City itself was hit quite early and hard. And so there was very limited data out there. Now there's unfortunately tons of data globally of patients of all different backgrounds and characteristics. But at the time when COVID first came to New York City, really there was Wuhan in China and Italy, right? And those were really the two places where there was data. It was still fairly limited. And so we wanted to try to think about ways to come up with data-driven recommendations so that there is a foundational base at which these decisions are being made, rather than a more ad hoc approach. And so this created a number of challenges. So one of the first projects that I embarked on was trying to understand the impact of personal protective equipment shortages. So you may remember that early in the pandemic, there was recommendations that individuals of the public who are not in the healthcare setting to not use masks. And in part, this was because there was a concern about shortages, right? And there turned out to be a huge shortage in those N95, the highest protective masks. And that got the most attention, but PPE captures everything from the face guards, gowns, gloves, booties on the foot, and there were shortages kind of across the board on these PPE. So why was this so concerning? Certainly, we want our frontline providers to be protected. We don't want to put them deliberately in harm's way. But also one of the biggest issues was that staff are the bottleneck resource. And in particular, really understanding the capacity to take care of patients was dictated by the number of staff that was available. So the Society of Critical Care, which is a group of clinicians, it's the Professional Society for Critical Care Medicine, put forth guidelines of what to do in the event of a pandemic. And so the way that this guideline works is that in the intensive care, which is reserved for the sickest of patients, typically there is a ICU trained physician that is managing the care of all the patients. Now, in the event of a shortage of staff, or in the event that there's such overwhelming demand, what the Society of Critical Care put forth was that the ICU trained physician would actually be in charge of non-ICU trained physicians. And so they would be managing multiple physicians that have different types of expertise. And there would be this pyramid to be able to treat more ICU patients. And so I know that a number of hospitals actually had to implement such tiered approach, where essentially one ICU physician was managing, 2 to 4 times the number of patients they would in a normal non-pandemic scenario. And so this was particularly concerning because even using these approaches, the Society of Critical Care estimated that at surge, so increasing capacity maximally, there was space to treat 135,000 ICU patients simultaneously. But some of the early projections said that there would be 200,000 to 2 million ICU visits. And so the question is, given this imbalance, what would happen to those patients? So what we wanted to do was to take an analytic approach. And so there are a number of different components we looked into place. So first, we built an epidemiologic model of transmission of COVID-19. Because this was early on in the pandemic, we also were looking at historical data of flu-like spread. So remember, this was at the time, this was in the winter where flu was still propagating. And so one of the concerns was that because we had limited testing capacity, if anybody, any provider exhibited symptoms, flu-like symptoms, COVID-like symptoms, they were asked to quarantine for 7 to 14 days. And so there was questions if somebody could have had the flu, and then we're removing that staff from our capacity. And then there are some people who may have contracted COVID, and they would also be removed. And so what we wanted to do was try to understand, depending on the availability of PPE, how would this translate into the number of ICU data, number of ICU beds available. So we created this simulation, and so here's just some results looking at the evolution of the pandemic since the first from that lockdown, and what would the difference be in ICU capacity. So what is the difference in the number of patients that could be treated, depending on how much PPE was available. So what we were considering is if there was full availability of PPE, of that N95 quality, versus people were using cloth masks or reusing masks, which certainly degrades the quality of the protection. And so depending on what would happen if there was limited personal protective equipment, we saw that in New York City, this would have a big impact on the number of patients that could be treated at that peak. So you can see this gap here, that depending on what the efficacy was going to be, that it could be up to 9,000 fewer patients that could be treated. And so that was a big issue that we were concerned about. And so what we did was we actually showed these results to the hospital, and tried to put forth that the emphasis of the importance of getting PPE. And I guess I should state that everybody knew that it was important, but the value here was not saying yes, get PPE for your staff. It was not only is it important for the safety of your staff, but it's also important in terms of your ability to treat the patients that we expect to be coming in. And so there was a big push to try to increase that overall availability. So that was one of the projects we did, and then we transitioned to looking at other impacts of what could happen in the ICU. And so with that huge demand for ICU, there were concerns that would result in shortages for ventilators, that for patients who are in respiratory failure are an essential component to life-saving therapy. So many different hospitals were doing various things. They were procuring ventilators. Some states were shipping their ventilators to New York. Some hospitals were experimenting with putting multiple patients on a single vent. But there was this therapy, and a collaborator of mine at Montefiore reached out to me that said, hey, you know what? When there is respiratory failure in patients, oxygen therapy, actually high flow nasal cannula. So that's actually with the rubber tube that goes in directly into the nostrils of a patient, and it pushes oxygen in through the nostrils into the lungs of the patients and helps them breathe in that way. And it has been shown in non-COVID cases to reduce the risk of a patient needing to go on a ventilator. And so this physician came to me and said, is it possible that this therapy could help reduce the risk of ventilator shortages? And if so, what's the best way to utilize this therapy? So again, taking an analytic approach, we started with an epidemiologic model of transmission to see what is the potential future demand of COVID coming up, and consequently ventilator demand. We used data on respiratory failure and COVID. And so I noticed there's a question with getting access to data and the confidentiality requirements. I'll talk about that more broadly towards the end, but in this particular setting, we were working directly with the hospital. We got a review from the internal ethics board that would allow us to utilize that data. But again, even though this was one of the hardest hit hospitals in the city, there was still relatively limited data available. And so we used data, historical data on respiratory failure to try to calibrate it. The way that we did this was we looked at prior respiratory failure, and our clinician collaborators would look and say, how do COVID-19 patients compare to this? And they tended to have longer stays on ventilators and different type of risk. And so we adapted the data points to account for that. And then finally, we used simulation to look at the different strategies of using this high flow nasal cannula oxygen therapy and tried to see, how many lives would be saved and what would the impact be. So what we ended up finding is certainly the number of lives saved depends on the availability of ventilators. So that's the x-axis. How many, and this is in thousands, how many ventilators are there available in New York City? And then how many patients of different types would die? And so each of these curves corresponds to a different policy. So the black curve is kind of that status quo, which had been used in the past, which is do not use high flow nasal cannula. And in fact, many people weren't using that even for respiratory failure because it's relatively new that there were studies that showed it was helpful for patients in respiratory distress. The green curve is a policy that we looked at that was don't use the high flow nasal cannula, but you may actually put patients who are at risk of deteriorating. If you have enough excess ventilator capacity, you may put them on to supplement them. And then finally, this is the policy that uses the high flow nasal cannula. And so we found that actually being proactive, identify patients who are most at risk of eventually deteriorating and needing a ventilator. If instead we put them on high flow nasal cannula, some of those patients would actually never need to get on a ventilator. Some of them may end up needing to have a ventilator, but because we were able to actually pull out some of the demand, we found that by doing this nationally in the United States, using this strategy could result in 20 to 80,000 fewer deaths. And in New York City, this would translate to 3,000 fewer deaths, which is quite remarkable. And so I would say the finding of this work suggested that using this particular therapy was a great approach to kind of supplement and complement the ventilator capacity. As a consequence of this particular work, one of our collaborators is actually a physician in Miami. And Miami, if you look at the trends, Florida saw their peak much later than New York. And so because of her involvement in this work and because of these findings, she was able to plead with her department head to make sure that they had the machines to enable high flow nasal cannula, that, given our ventilator capacity, we can help supplement with high flow nasal cannula. And that is actually what was done. And as the pandemic has evolved, the use of oxygen has become much more prevalent. And you may have read about some of the shortages of oxygen because it became a much bigger approach to combating patients in this particular setting. And so then I guess what I want to do is spend a little bit more time on this last topic, which was, I think, very important both for their perspective of the hospital, but from a public health standpoint. And the question was, what would a second wave look like? So in New York City, we didn't know what the true spread of the disease is. We didn't know how many people have been infected. In fact, I believe we don't still know the accurate number of people that have been infected. But certainly in New York City, because testing capacity was so limited at the beginning of the pandemic, people who exhibited symptoms were told to assume that they had it and they wouldn't get tested. People who were exposed were not getting tested. And so we had no idea what the spread was. Now, this is important because we were working under the assumption that if people had been infected, there was a lower chance of them being reinfected. And so, we've heard the term herd immunity. How close were we to herd immunity? And that's going to also impact, if we were going to have a second wave, how quickly would things evolve? A second challenge was that we didn't actually, and still don't have great estimates, but it's getting better. What is the risk of hospitalization and death for patients, for people who contract COVID-19? And again, this is because we didn't know what the true numbers of infected was. We knew what the numerator is, right? We could see how many people had died in New York. We could see how many people were hospitalized, but we didn't know what number to divide it by. We didn't know how many people had been infected. So what was that risk? And so if we think about the hospital trying to plan, New York was hit hard and fast. And so there was certainly a scramble to get enough staff to treat all the patients in that March, April time period. And the hospitals were trying to plan for the fall so that at least if there was an increase in demand, they would be prepared to be able to treat those patients. And so understanding the risk of hospitalization and projecting how many people are going to be hospitalized was a big, big factor. And then finally, another challenge is that it's really difficult to predict what people were going to do, right? And I think it varies from community to community, but there were various lockdowns and how many people were going to adhere to lockdowns as things start to open up. And thankfully, things are opening up very rapidly here in New York City. But at the time, we didn't know how many people were going to adhere to mask mandates, how many people were going to limit their interactions with people outside of their household. And that would have an impact on how rapidly the disease would spread. So there are a lot of open questions, but we wanted to be able to provide some insight, again, because a lot of operational decisions were going to be relying on these types of projections. So the approach we took was that one of the wonderful things that the Dean's Office at Columbia Business School did that summer of 2020 was create Dean's Summer Fellowships. And so I had 3 students working with me on this analytic project for the summer. So the first was Paula Lopez, who just graduated with her MBA and went to go work at McKinsey. And then 2 students who are in our master's program, Masters in Business Analytics programs, who were kind of doing a lot of the number crunching and scraping of data from the web. So this was a very student-run project working closely with me on trying to come up with this. So what did we try to do? We wanted to try to address those big questions that we felt were open there. So again, we were using a epidemiologic model of transmission to see how things were evolving. We looked at how many deaths there were in New York City. And so while we can debate offline the imperfections in that number, it was far more reliable than trying to understand what are the total number of infections in New York. Then what we did was that we needed to estimate how long people are sick for, and in fact, how long they would stay in the hospital if they were hospitalized, using, again, data, publicly available data on the number of hospitalizations that existed. And then what we used to try to infer the prevalence in New York City was we used data from other countries. And so many other countries took a different strategy early on in the pandemic and had a much more robust testing strategy. As a consequence, they had more data in terms of the incidence and mortality. There were also some countries that ended up doing randomized seroprevalence studies to get a better understanding of their mortality and prevalence. And so here we used this data from other countries to help us understand what is the true mortality rate, so that given the number of deaths, we could reverse engineer to figure out what the potential number of cases were in New York City. And that would allow us then to do projections of a second wave. So I won't go into all of the details on the analytics. This took quite some time. The students were pulling data from all different countries. Each country reports their data in a different way. The reliability of the data is quite different. And so sorting through all of that, ultimately, based on comparable infection fatality rates that we estimated, and we used data, I believe it was from Spain and Switzerland, where we found to be the most reliable. We estimated the percentage of people who are infected to be about 30% in New York City. Now, there were studies that were done testing seroprevalence in New York City, and they found it to be lower. And so we feel that there is likely a bias in those estimates because they weren't conducted in a random way. And in particular, the way that it was being done is that people would, the team who was doing the study went out on the streets and were asking people if they wanted to get tested for antibodies. Now, the issue with this is that people who are currently infected with COVID should not have been walking about on the streets, presuming that people actually adhered to quarantine measures. People who were exposed, but even if they were asymptomatic, were also not walking around on the streets. And so there was a big cohort of people that actually are higher risk of testing positive that weren't in these studies. And so we came to the conclusion that actually likely the infection rate in New York City was much higher than it was originally thought to be. And so we were looking at what would happen if, as things started to open up, how likely there was going to be a second wave. So you may remember a term that was a big focus at the beginning of the pandemic, this R0, which is essentially the measure on average, how many people does an infected person subsequently infect? And so there were estimates early on in the pandemic that without any measures being taken, that R0 was 2. With all of the various interventions that were taken, we were able to reduce it to below 1 to lower the cases in the United States. But you would expect as things opened up that this R0 could increase. Now, the baseline R0 for these variants that are existing out there, such as Delta, is likely to be much higher than 2. But some people are still taking precautions. More people are vaccinated, and so the risk is quite different. But we were looking at different scenarios, and we said if this R0 increases above 1.5, which, to be frank, didn't seem like a really large number. It seemed reasonable to expect that that could happen. We expected that the second peak would happen around January of 2021. And we estimated, depending on this R0 value, that the number of hospital beds that would be required varied from 1,500 to 9,300. So to kind of dig in a little bit, and we did this work in July and presented it to the hospital. So you could see what would happen depending on this infection rate. There was a number of scenarios where there was not going to be a second wave, that we were past the peak, and that while cases would not go to zero, they wouldn't start to increase again. But as you increase that R0 value, you could see that there were differences in the number of active cases, and the number of beds was going to vary quite a bit. And here we could see the date at which we expected that peak to occur. So I see a question of like, how well did the model do in reality? And so what it was the actual pandemic trajectory. So here's the timeline from April 1st to for 12 months. Here's the initial huge peak that occurred, and then over the summer, cases dropped substantially. And then you can see here that cases seem to peak mid-January, early February period, with the peak hospitalizations being about 4,000. Now, we had to make a lot of assumptions in our model. We were still working with relatively limited data at that time. And so I guess as a looking back perspective, it was nice to see that even using this limited data, that the initial projections were reasonably close, that we could avoid this really big peak that was seen in the March-April time period of 2020. And when we showed this to the hospital, these original projections, they felt comfortable that they would be able to enact policies to meet this type of demand. But you can see that as that R0 starts to creep up, and certainly with the presence of variants, there was concern that if things started to get out of hand, like it was possible that that really nightmarish situation could return. And so the conclusion was, in working with the hospital, yes, we need to work together. We need to try to monitor how that R0, and there are a number of different places that I've been trying to estimate that real time. How is that increasing? Can we be sure that we are prepared in that January, February time period to meet that increased demand? And we cannot let down on the public service announcements and education of the importance of masking and hand hygiene. Certainly things now are quite different in New York, where I think last I looked, I think it was 56% of all New Yorkers are vaccinated, and that includes children that are not able to be vaccinated. And so I guess what I want to highlight with these three different projects is that a lot of the decisions that were being made surrounding COVID-19 were made in a very ad hoc, intuition-based approach, in part because it's a novel coronavirus, right? Nobody had seen it before. There was a lot unknown, and so people, rightfully so, were doing the best that they can. That said, as the pandemic evolved, much more data became available, and so it became possible to try to utilize this information to guide more data-driven, more evidence-based strategies to address the pandemic. So just to summarize, I talked about these three main areas, the modeling of PPE, the use of ventilators and high flow nasal cannula, and these second wave analytics. I mentioned I'm continuing to do a bunch of work going forward, and so it's not over, but things are definitely improving. And so thank you for your attention. I see a number of questions, so I'm excited to get to them.
Professor Chan, are you gonna go in there and choose questions, or should I read some off to you?
If you want to read them off, that's great.
Sure. All right. So the first question we have here is, what challenges are there with access to data and confidentiality when undertaking healthcare analytics?
So rightfully so, that is, I would say, the biggest challenge. From a research standpoint, I've been collaborating with a number of different providers. And so we take approaches in terms of there's what's called an internal review board. It's an ethics review board that we submit to them, tell them what we're planning on doing with the data, and to make sure that we're using it in an ethical way and protecting the privacy of the patients as much as possible. We do our best to only extract the data that is truly necessary. So for instance, names, we try to just assign patients an ID number, so we don't have names. In some cases with address, we'll just use their zip code. For age, we'll actually have the team pulling the data give us the age rather than the date of birth. And so we can obscure as much as possible the information to protect privacy while still maintaining the value of the data. Obviously, if you do too much, there's no value in that data. So for example, one common approach to obscuring data is assigning randomized admission dates. So you have the same duration of the stay, but some patient maybe, instead of it being admitted on January 3rd, was admitted on January 4th or 30th or February 10th or whatever. Now, that is very useful in some studies, but for what I do, because I look so much at the system, trying to understand how the interactions between other patients impacts the access to care, we actually need to know how many patients and which patients are there together at the same time. So depending on the study, we do various things, but it is a big challenge, and we do everything we can to protect that data, storing it on encrypted servers and the like.
Thank you so much for that really thorough response. I think that was really helpful. The next question that we have is, do you foresee a lot of transferability between what you learned during the COVID-19 pandemic and future public health risks?
Yes, absolutely. I think that a lot of people, myself included, but a lot of people in the data analytics community kind of realize there's a lot of tools that we could use to help in this. And so there's just been a explosion of work related to COVID-19. I think those skill sets are easily transferable to other disaster scenarios. I specifically in a lot of the projects that I'm continuing to work on, the methodologies that we're developing can be applied in other settings. And so taking data from other pandemics, knock on wood, we're not going to see one of this nature in our lifetimes, but I think that it can certainly be helpful going forward.
Yeah, I think, that's such a top of mind question for so many people, right? Of course, hopefully we won't all live through another pandemic of this scale, but just being more aware of potential public health risks out there and being prepared for them. So thank you. So this next question is actually about CBS. One of our attendees is wondering if you could talk a bit about what courses are available to our MBA students. Sorry about that. Who want to learn more about data analytic programs and how to use them to drive evidence-based decision making.
Yeah, so that's a great question. you probably know that one of the strategic pushes of the school, and that Dean McGlaris has been really highlighting, is this focus on analytics. You may or may not know that we're the very first of our peer business schools to offer an analytics course in the core. So we have business analytics in the core, which all students are going to take to expose them to analytics. And then we have a wealth of electives that are associated with it, from, looking at, so there's a business analytics 2 that is more tools based. We have a seminar that is actually taught by 6 different faculty members who come in and talk about an industry, their industry of expertise of where they're using analytics. So I come in and talk about healthcare. We have people that come in and talk about the sharing economy, people that talk about Bitcoin, recommendation systems. So you get kind of a full perspective of analytics. We also have classes that teach coding. So we have a Python class for MBAs who want to get their hands dirty with the data, rather than being in kind of a more project management type of role. And so there's a lot of courses. I could probably spend the entire hour talking about all of them, but I assure you that we have a lot of them. We actually have one really cool master's class that is called the Analytics Advantage, and it is taught jointly with the engineering school. So about 3/4 of the students are MBA students, 1/4 are engineering students, and they work on company-sponsored projects on an analytics project. And so you get really good opportunity of working closely with companies. You get a real interdisciplinary perspective of these things. And so there's, I believe, like a really large wealth of opportunities if that's an interest for you.
You actually beat me to my next question, because the next question was, will there be other opportunities similar to the one you described from last summer for students to get involved with, data analytics fellowships or projects? So I think that was, you beat us to that one. So the next question here is, based on your experience in digital health, how have you seen hospitals or medical providers leveraging data to improve equity? This question, they gave the example of, for example, in the triage process.
That's a really great question. And so I mentioned that I'm working on this ventilator triage project. And one of the things with triage, unfortunately, this means when you have an imbalance between supply and demand, that sometimes patients are excluded from treatment. And that's a very heavy and challenging decision for providers to have to make. What we've been working with a clinical ethicist to kind of complement our algorithm design. And so in doing that, I think we have to be very careful about what exists in the data. So as an example, if we threw the kitchen sink, just like all of the data that we had available, and our goal is to maximize lives saved. Well, especially with COVID-19, there are certain factors like diabetes and obesity that are associated with higher risk of poor outcome. And so that could mean that certain patients with those features would be moved down the priority list. Now, when working with our clinical ethicist, she, urged us, not to throw the kitchen sink in terms of data, to think about the ethical repercussions of what we're implying, especially that, there are communities who've had lifetimes of limited access to care, less health equity, resulting in a higher prevalence of these types of diabetes and obesity. And so she had us consider what would happen if we excluded those variables from our algorithm design. And in fact, the difference in performance is fairly limited. And so there's an argument to be made that to ensure equity, that we can reduce that initial, efficiency metric. And how do we balance those together? And so that's an ongoing debate that people are having. We actually, a CBS alum, and maybe butchering her last name, Julia Ayasari, is now the head of the Dalio Center at New York Presbyterian, which is focused on work related to health equity and access. And she's actually going to be speaking in my healthcare class this coming fall. So it is a topic of mind at CBS and the providers that exist here.
Thank you so much. And thank you for that little glimpse into your class for this fall. So looking at the clock, I think it makes sense to do 2 more questions, if that's okay with you. So the first one is, one of our attendees was hoping you could speak a little bit more about your role in employing your findings to influence policy changes, practice changes, and kind of the timeline of what that looks like.
So it varies. In these particular projects with COVID, because of the rapid pace at which things were evolving, a lot of what I did was to reach out directly to hospital leadership and present work to them and speak with the various stakeholders. And so that was something we worked very hard to try to inform decisions. For the more standard research that I'm working on, we take a much more deliberate and careful approach. And so, I'm embarking on an implementation of a new scheduling algorithm with a hospital in New Jersey, but we're taking our time to, carefully design the intervention and the pilot study to make sure that we're doing it as carefully as possible. But I do work with a lot of people in hospital leadership. My view is, from an impact standpoint, there's a number of different ways to get it. One could be speaking to leadership, and maybe they don't directly implement the algorithms that are being recommended, but we change their way of thinking, that these are factors that need to be considered in making decisions. And I think that is so critical. And that has been something that I feel like I've had quite a bit of success in. And then the other is direct implementation. And so I'm embarking on that with a number of projects, but that's a much longer process.
Thank you so much for that additional insight into your work and your process. And so I think this last question is a good one for us to end on. We have a question about, how do you see major social events such as the COVID-19 pandemic, impacting the curriculum in the healthcare and pharmaceutical management program going forward? Do you think there will be any changes or additions or anything like that coming out of this global experience?
Well, that's a big question. I guess the short answer is yes, I see a lot of changes. I think first and foremost, I think it has put the healthcare system front and center, and how it impacts everything that we do, and not just for individuals on a day-to-day basis if they get sick, but just the way that our supply chain has been completely disrupted, is now impacting various industries, such as the car manufacturing industry. And so I think people are going to be more aware, especially as the threat of these types of public health issues are unfortunately seem to be increasing, that there's going to be more preparation. So I guess that is one silver lining, that people hopefully for the next one will not be caught as off guard, that if there is a new disease coming out there, that measures will be taken early. So instead of complete proliferation, that approach of identifying, quarantining, and sculpting it early on is something that is going to happen. But I think there's a lot of questions on building resiliency and flexibility in multiple different industries as a consequence. So I think it's for better or worse, it's an exciting time because we're in a field of transition. I also think that especially in the healthcare space, there's now been a huge push for more data analytics to guide decisions in a more evidence-based approach. Now, that had always been done kind of on the clinical trial of medication approach, but I think that a lot of the more operational and strategic decisions can also be made using evidence. And so I'm excited. It's a great area to be in. So, I'm selfish that's great for me. But I also think there's a lot of opportunity for students to get involved, whether they're working directly in the healthcare space or kind of interacting with it more peripherally.
Thank you so much, Professor Chan. And I know that was so helpful for everyone here today who is, learning more about Columbia and HPM, and excited about, the opportunities here at CBS. So thank you so much for your time today. This was so wonderful. And thank you to everybody who joined us today. We really appreciate your time. If anybody has any follow-up questions from today, please feel free to reach out to the admissions team. Our email address is apply@gsb.columbia.edu, and I'm putting that into the chat for all of you now. We really look forward to seeing you at future admissions events. We have lots going on for the rest of the summer and into the fall. So we really look forward to seeing you all again. And just once again, thank you so much for your time, Professor Chan.
My pleasure. Thanks, everybody.